Hello and welcome to the Triage Method podcast with me, Gary McGowan, and my co-hostess, Dr. Nicola Flanagan this evening. How are you, Nicola?
I'm good, thank you.
Very good. Paddy is absent this week. He's walking Hadrian's Wall in England. So I don't know, are they walking from east to west or west to east, but himself and Mike Delaney are off trekking. So we hope he enjoys himself. This week, we're going to be talking about women's health screening. We've obviously talked about so many things now. We're on episode 21 of the Women's Health series. So we've covered so many topics. And I think to some extent that can be very overwhelming because you get all this information and then you're not left with any understanding of, right, what should I actually be worried about, as an individual when it comes to my health? And I think understanding the screening needs and what's worth screening for can be helpful for you to understand based on, where you are in your life, what your risk factors are, etc. So screening is an interesting topic for a number of reasons, because I think in some cases, what people think when they're maybe outside the healthcare world, especially even among a lot of personal trainers, people assume that testing for the maximum amount of diseases, the maximum amount of blood markers, the maximum amount of scans, all those types of things, a lot of people assume that that is a very beneficial practice, that the more testing you do, the more problems you can identify, the more problems you can fix, and therefore the better your health will be. But unfortunately, it's not that simple for a number of reasons. One, healthcare resources are always going to be limited. So if we screened everyone for everything, that would be a waste of resources and it just wouldn't be possible. So from the kind of public health and the doctor's perspective, what you have to think about is, what is actually worth screening for? What's a good use of time? If we employ a given diagnostic test or screening test rather, who is it actually going to help? Is it worth screening for, let's say 20 to 25-year-old males that go to the gym? Or should we be screening for diabetes in that population? Or would it be better to screen in maybe an overweight population in between 40 and 50? The latter might be a better use of resources. So this is one of the issues we run into with screening, because screening effectively is the use of investigations to assess for the presence of disease or markers of disease in asymptomatic populations. So you're often looking for, diseases that may become a problem around that age or in that demographic when they're not actually presenting with symptoms. So this isn't the same as, for example, someone presenting to their doctor with, they're coughing blood and they've got shortness of breath and they're a smoker and they've got established signs of lung cancer. The diagnostic process from there isn't screening as such. It's more so diagnosis. Screening would be let's say using a chest x-ray or low dose CT or something like that to identify lung cancer in a population of smokers who have no symptoms, for example. That would be considered screening. And there's two important areas of screening, or two important characteristics of a screening test, I guess you could say, which are sensitivity and specificity. So a test that is very, 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 very sensitive is going to pick up all of the cases of disease, but it's also going to tell a lot of people that aren't diseased that they have some sort of disease. So for example, if we take, let's say, a blood glucose cutoff for diabetes, and we put the threshold at 5.5 millimoles per liter of blood glucose, you're probably going to catch the vast majority of people that have type 2 diabetes, but you're also going to get a load of pretty healthy people that don't have type 2 diabetes and now put them in that bracket. And then similarly, so you can say that test isn't very specific, okay? But then on the other side of things, if you were to take the cutoff and let's say move it to 20 millimoles per liter, now you're actually going to miss a lot of diabetics because there's a lot of people below that threshold that would have diabetes. But we're also not going to have all those healthy people in that bracket, but we've gone too far in the other direction now. So there's a kind of a balancing act there between a test that's sensitive and a test that's specific. It's never going to be perfect, but you want to find some sort of middle ground. So a good screening test is going to identify most of the people with the disease, but there's still going to be some people that maybe are told that they have the disease or might have the disease that get picked up. And similarly, there's going to be some people that do have the disease that don't get picked up. And that's just the nature of screening. It's never going to be perfect, but balancing that sensitivity and specificity allows us to get close. And you can see some examples of that as we walk through different screening tests moving forward. So, Nicola, do you want to discuss kind of I suppose in general, or maybe you have something to say on what I've just said. Anything to add there?
Yeah, I suppose the main thing is we're going to be going through lots of different screening that women can get, but the biggest thing to take from this is, this isn't a list of things to worry you or to be like, I need to go out and get all these tests. It's not something to worry anyone. It's just to, I suppose, raise awareness about potential screenings kind of throughout a woman's lifespan, just so you don't, I suppose, miss certain milepoints.
Perfect. And I suppose as a general overview to start with, what are some of those kind of main pillars of disease that women should be getting screened for in general?
Yeah, so one of the big ones, I suppose we all know about the, cervical cancer awareness over the past couple of years been made major headlines. Unfortunately, in a lot of cases, for the women, but I suppose what's come out of that is a huge amount of awareness about cervical cancer, which has been, fantastic. There's a much greater uptake in women utilizing the screening, getting smears, and as well getting the HPV vaccine. There's been a much greater uptake as a result of that. So there were some positives to take from, a largely kind of negative situation. So obviously the cervical cancer check is a huge one, breast check that we're all aware of. And then there's other ones that are more specific kind of to certain lifespans. So just say, we'd be looking kind of at the pregnant population, what they would be getting screened for either kind of prenatally during the pregnancy. And then we'd be looking at kind of postmenopausal populations, whether that's osteoporosis risk, colorectal cancer, kind of, etc. So those are some of the main ones. And then STI check for the whole population.
And I think you made a couple of interesting notes here in relation to screening criteria, which kind of, I guess, add to what I mentioned previously, in that for a screening program to be worthwhile, we have to have a couple of things in check. So number one, we want it to be a public health concern, of course. And in this case, let's say cervical cancer or breast cancer, it is a public health concern because we can see that, it actually does have fairly, or there's a significant portion of the population that have this disease. If it was the case that there was some sort of obscure disease or some rare cancer that was only present in 0.0001% of the population, that wouldn't really be worth having a screening program for because it's just so rare. So that's one of the things that's really important to note when it comes to screening. Another thing then is that there should be an early asymptomatic stage for that disease, because if there's not an asymptomatic stage, then we don't really need to screen for it because people will present to their doctor once they get symptoms. And unfortunately, for a lot of cancers in particular, there is kind of a long asymptomatic period. And in some cases, a cancer could be growing for years and years. And it's only at the point when it becomes a lot more serious that people start to have symptoms, and then it's more difficult to treat. So you can see there that it's very worthwhile having that screening program in place to pick up people earlier so that their outcomes can be superior. And on that note, then, there should, of course, be a suitable screening test. Okay, so we need some sort of screening test that's present. And as we'll discuss in the case of cervical cancer, you can see how that's changed over a number of years. It's not like there's just one test for the screening program and that's just it. There are evolutions over time as well. And then, of course, we want to ensure that there's a treatment available. Okay, so the idea there being that if we can screen in that asymptomatic period and treat early, the person has better outcomes. That's in the absence of a treatment being available, basically just telling people they have the disease earlier. So it's not really a win all around. And then finally, we ideally want that early treatment during that asymptomatic stage to improve the long-term outcome. Okay, so if it's a case that treating at 1 year post onset of disease versus 10 years post onset of disease, if the outcome is the same anyway, then screening in those populations isn't necessarily as important. An example of that comes up over and over again is, for example, prostate cancer in elderly men. If you've got a 90-year-old man, let's say, if you've got a population of 90-year-old men, I should say, you're going to have people in that population, or a lot of people in that population, if not most, that are going to have an elevation in prostate specific antigen, which is one of the things that is tested for, and in a large prostate and some degree of prostate cancer that might be going on. So if you're screening that population, it's not so clear that, you know, by treating it or investigating it, that you're actually helping that man, because it might be the case that he just dies with the cancer and it's not changing his outcomes. So there has to be clear that it's worth testing for, the test is effective, there's a treatment available, and that treatment actually changes long-term outcomes. If we don't have all those things in place, a public, you know, screening program isn't going to be particularly effective. And that is one of the reasons, or they are some of the reasons, that, you know, we don't have the HSE or the NHS or the WHO screening for every disease under the sun. It just doesn't make sense. There's a few big ones that will be screened for, but not everything, because again, there's limited resources, an infinite number of problems, and that's always going to be the case with healthcare.
Brilliant. Yeah, so particularly with the cervical check, it's a really good example of like everything you went through, Gary. So like you're saying, it has, you know, an asymptomatic period, and the treatments when it's caught early are like really, really good outcomes. So I suppose cervical check, for anyone that's not aware of it, it's where, you know, women or anyone with you know, a cervix can go into to their doctor, or a nurse can do it, and basically it's like a, you know, a small brush that's kind of inserted into the vagina, and then it takes samples of cells kind of around the cervix. This is just at kind of the opening of the uterus or the womb. And then so it's available from women kind of the age of 25. And why 25 is that age is because when it's done in a younger age group, a lot of kind of false kind of positive results come up, okay, because there's a lot of kind of changes up until that age. And still after that age, from age 25, it still does pick up a lot of you know, atypical cells that aren't very worrisome, that don't exactly mean kind of cervical cancer. So that's like very common for it to be kind of picked up at that stage. So HPV is kind of one of the things that they're looking for. And a lot of women will have received kind of HPV vaccine kind of when they were younger, but there's so many different types of HPV. And a lot of us will be exposed to it, you know, kind of at some point in our lives. So the vaccine, it only covers kind of a certain amount, kind of the most kind of serious kind of HPV kind of variants. But we can still pick up HPV even kind of with the vaccine. It just kind of gives us a better, you know, advantage essentially. And you want to be kind of getting the vaccine kind of before you're sexually active as well, or else you could already have contracted kind of HPV. But basically on the age 25, it's recommended to kind of get a cervical check every 3 years up until the age of 29. And then after that, it's every 5 years. And it's really easy to register online. You just go in, you kind of put in your PPS number, your address, and then you get a letter sent out. And then on your letter, you're kind of given this number. It's like a cervical check, cervical screening program identifier. And then you go into your GP or kind of the nurse, and you give them that number. And then you'll get a letter out to you kind of with the result. And again, it's, you know, if it detects HPV or HPV or atypical cells, it's kind of not to panic, because there's many changes that can occur in the cervix, and a lot of them kind of will go away on its own. A lot of them don't even need treatment. So it's at that stage, kind of don't panic, and it can be completely normal. And then if you need further testing, you'll kind of be brought in for that. And the most important thing is that you just do get in and get checked. It's a really quick and easy check to do, and that can save your life, I suppose.
Yeah, and I think it is a good example because if I recall correctly, previously it was just the smear test, whereas now it's the smear test followed by, is it PCR for HPV? I think that's the process there, the steps, isn't it? So I think that's a good example of where you've got like a stepwise process. And then if, let's say, there's a abnormality detected or the presence of HPV, doesn't necessarily mean that the treatment needs to take place at that point in time. But what it does mean is that you can modify subsequent screening intervals. So going from every 3 years to, I think, is it every year? that they change it to?
Yeah,
Uh,
it can change, and even like, women do get it below the age of 25 as well. It's not that you can't get, a smear until you're 25. It's all kind of stratified by risk, but just at the minute, the screening program is kind of 25. But then, if there are kind of atypical cells, or if it's women that have the kind of higher risk HPV variants, they will be brought in kind of more frequently, just kind of, depending.
Yeah, so I think that's a really good example of like some of the principles of screening in practice, where the test gives you a signal and then you're modifying the subsequent intervals. So you're not just saying, again, it's not like every woman comes in every year, regardless of age. You're identifying risk factors and then screening appropriately. So there's some of the principles of screening in practice. Anything else to say there on cervical cancer side of things?
No, I think, yeah, just kind of, get in, get checked. Like I said, it takes 5 minutes, it's gonna be something, it seems like a pretty kind of invasive test, but it really is kind of just, 5 minutes, and, it's done. So just, yeah, get in and do it.
Perfect. And what's next on the list?
So the next one is STIs, or sexually transmitted infections. So I suppose this is important for, anyone who's sexually active. And I suppose there's a whole list of STIs that we could go through, and which I don't think is particularly necessary. But the biggest thing to come out of this is, like that it used to be that you used to have to go into your GP practice, kind of, ask for, an STI check, which was a huge kind of barrier to getting checked. So people were really only, going and showing up to their GP practices if they were kind of symptomatic, or if they found out that, someone that they had sex with has an STI, which just meant that there was, there is a huge amount of kind of STIs going around in the population. But now there's actually the HSE and Sláintecare, they're doing home STI kits, which is absolutely fantastic. Again, you just kind of go, you kind of register online, and they'll send you out a kit to your house. So it checks for kind of HIV, chlamydia, syphilis, gonorrhea, Hep B and Hep C, which is just like fantastic. So this is important, again, for, anyone who's had kind of, multiple sexual partners, or a new sexual partner, or that's aware that someone that they were with has contracted an STI, anyone with symptoms. And these home kits, again, like, have just kind of, changed kind of the outlook for, a lot of people. It just means that there isn't that kind of stigma of kind of going into the GP anymore. It's a quick test at home. So for women, it's kind of a swab in the vagina, and then a blood test as well. So just kind of prick on the finger, and then you send it back off. It's tested for you, and then you'll get the results back as well. I think with the HSE, they text them to you, which is great, and again, it's important for those populations, because left untreated, a lot of like STIs don't have symptoms, unfortunately, which is how a lot of them kind of spread so quickly kind of in the population. But particularly for women, if like chlamydia or gonorrhea is untreated, it lead to like pelvic inflammatory disease, which has knock-on issues of a lot of kind of pain, and then like potential kind of infertility kind of later on. So it is important, if you are kind of in any of those kind of risk factors for getting an STI, that you do just kind of log on, get one of those home free tests.
Yeah, and I mean, it really does reduce the friction when you can just get it sent out to the home, because
Yeah.
even going to the doctor when you are sick is a big enough step for people to take. A lot of people just aren't bothered to go to their GP. You have to get the time off, you have to get an appointment, you have to pay the money, blah blah blah. Whereas here, you just get your test sent to your home. So it is a really nice step, especially in the case of STIs where there is stigma associated with it. The next one, I suppose, is one that it's not necessarily just for women, and I think it's one of this is when we talk about blood lipids, which is the next one. Like, blood lipids is one of the kind of very, very few things where I think most people can benefit from having a look at some point in time, like, right, where are your blood lipids at? Because the thing here that's interesting is that when we talk about blood lipids, for example, your LDL cholesterol, you're talking about a very long latency period between, the elevation in LDL and the eventual cardiovascular event. You could have, high LDL from your 20s, and it's really only maybe 50, 60, 70 when you might eventually have an event, depending on how high it is, of course. And unfortunately, there's not really any signs up to that point. You don't get symptoms of high LDL. Like in some cases, some familial hypercholesterolemia syndromes, you can have, certain signs, but it's quite rare that you're going to have, xanthomas or xanthelasmas, these types of things that present themselves. Most people are going to be asymptomatic. So it is useful to have some sort of baseline test when you're young, male or female, doesn't matter, just to get an idea of where your LDL is at. And I think this is really useful for, I guess, our listeners, who are generally fit and healthy people, or generally at least some degree of they're quite health conscious. You can be eating a perfectly healthy diet, and if you have familial hypercholesterolemia in your family, for example, you're still at risk, and you can do what you want with your diet, and it just might not be enough. So it is really worth screening in this case, and potentially even treating. So again, there's still some degree of risk stratification here, which is important. So if you have, let's say, a normal test first and foremost, a lot of people might need to test that again for a very long period of time. But if you've got a high risk of cardiovascular disease, so for example, if you're older already, if you've got hypertension, high blood pressure associated with that, you've got diabetes, you smoked or currently smoke, you're obese, sedentary lifestyle, family history of early heart disease. So for example, maybe you're like, oh, I think my dad had a heart attack at 40, and yeah, my granny died when she was very young of a heart attack. These types of things might lead you to be a bit more suspicious or a bit more regular with your testing, or potentially your doctor might even decide to lower the threshold at which they're a bit more concerned. And that's an example of, I guess, the dynamic nature of screening, where someone might say, right, we're going to test at a given period of time, but given other risk factors, we're actually going to bring the threshold at which we consider it to be an issue a little bit lower. And that's something that's always evolving in blood lipids in particular, because what we know now is that the lower your LDL is and the longer it's low for, the better your outcomes are going to be in terms of low risk of cardiovascular disease. So there's the time and the magnitude that's important there. And then for women in particular, those in higher risk should have lipid screening again at age 30 to 35 or so. So if you're identified to be in high risk based on what we discussed previously, then again at about 30 to 35. So initially as a young adult, and then 30 to 35. If you're lower risk, you can wait till your 40s, recommended around the age of 45 if you don't have those risk factors. But it really does kind of depend. This is an area that's always evolving in terms of the levels. As I said, what was previously considered to be a normal level of LDL cholesterol, it's now a little bit more like, okay, it's normal, but lower is still better. So I think if you listen to some of our previous episodes on cholesterol and heart disease and those types of things, that's kind of our message, is that lower for longer is generally going to be better. And especially if you're in those higher risk categories, medical management might be required, but at the very least, dietary modification is going to be required. And that brings us on to the topic of pregnancy. Now, before we get into pregnancy, it is worth noting that a lot of this is going to be looked after for you. Okay, so if you happen to be pregnant at the moment, you just found out, it's such an overwhelming time already, and you end up, one of the things that a lot of women report when they get pregnant is they're getting advice from all directions from everyone that was ever pregnant in their lives, and it's very overwhelming. So thankfully, you generally don't have to think and manage all these screening tests or considerations yourself. Your doctor's generally going to look after it. So Nicola, do you want to discuss some of the considerations for screening during pregnancy, high risk, low risk, etc.?
Yeah, definitely. And like you said, the biggest thing there is, like all of this is going to be taken care of for you, so it's not to get kind of too caught up. So the purpose of this is just, to kind of raise awareness and kind of let people know what might be involved, if and when, they become pregnant. Two kind of main kind of conditions that women might get during pregnancy are gestational diabetes and preeclampsia. So gestational diabetes is basically when a woman can, with no history of diabetes, can kind of develop it during pregnancy, and then once they have the baby, that kind of goes back to normal again. So again, this isn't in some countries, this is a routine screening kind of across the board. It's kind of usually done kind of second trimester, 24, 28 weeks. In Ireland, it's not routine screening, so they'll just identify kind of people that are kind of at high risk for gestational diabetes. So these risks are, people that have, previous history of gestational diabetes, maybe in their last pregnancy or before that. If they've previously given birth to kind of a big baby, kind of over 4.5 kilos, if they have a high BMI themselves, kind of mothers over 40 might get screened, someone with a family history of diabetes, someone with PCOS, or someone that has kind of been on long-term steroids. So they're people that kind of will be screened in that age. Again, the screening first is kind of a really easy test. It's called an oral glucose tolerance test. And again, it'll be done in the hospital. You'll just be fasting for 12 hours beforehand. They'll give you kind of a sugary drink, and then they'll test your blood sugars again, test your blood again, kind of 2 kind of 4 hours afterwards. So again, quick kind of, easy test, but again, nothing you need to worry about unless you're in kind of one of those higher risk groups. And again, it'll be taken care of for you. I don't know if there's anything you want to add to that, Gary.
Yeah, no, not too much to add to that. I suppose just one of the things to note is like you said, it's not necessarily like gestational diabetes is not the same as having a diagnosis as, type 2 diabetes mellitus. Like I think the vast majority, not in all cases, but the vast majority of women with gestational diabetes do regain normal blood glucose control afterwards. It is a risk factor, or potentially puts you at risk of developing overt type 2 diabetes in the future. Most women do revert to normal glucose control afterwards. So if it does happen that you've had, if you do develop, let's say, gestational diabetes in the current pregnancy, that again is something that will modify subsequent screening in subsequent pregnancies. Again, demonstrating the dynamic nature of screening there. So yeah, that's the GDM.
Perfect. And then the next one then is preeclampsia. So this one might not be kind of as well known by women who kind of, wouldn't be aware. So this is typically, when a woman kind of over 20 weeks kind of goes in to one of their antenatal visits, and will have kind of a high blood pressure. So usually kind of, 160 kind of systolic. And so when they have that, it's kind of retested. And if it's still at that kind of, higher level, they'll check their urine as well. And if there's kind of protein in their urine, it's kind of signaling that they might have something called preeclampsia, which again, if it's left untreated, it can, kind of have kind of serious implications for kind of both kind of mother and baby. But again, it's one of those things that, every visit that you go for in antenatally, your blood pressure is going to be checked. You're gonna, do a urine sample. So there's lots of kind of checkpoints for this to be picked up, just like gestational diabetes. So not something to worry about. There are some higher risk people that at more risk of developing it, really. So that's people that haven't, it's their first pregnancy. People that might have had preeclampsia in a previous pregnancy, they're more likely to get it again. Some of the family history, or if with the history of chronic high blood pressure, if they have renal disease, if they have some other kind of vascular disease, diabetes, and then obesity is another risk factor as well. But these people, again, they'll have kind of their baseline blood pressure kind of from their first antenatal visit, and then what they'll do is kind of have more kind of accurate kind of estimation of the gestational kind of age of the baby. And that's because preeclampsia can put you at high risk of kind of having kind of a smaller baby essentially. So they'll do that, and then they'll check kind of the baseline bloods, that again kind of later on kind of for someone with preeclampsia, we'll just kind of test if it increases in severity throughout the pregnancy.
Perfect. And then obviously there are some of the specific conditions you might be concerned about, but there is kind of a general standard panel that, if you are pregnant and you go and see your doctor, and they're going to do some blood tests. Some of the standard things that they'll generally test for would be your rhesus status, which is basically a marker in the blood that can be incompatible between you and baby, and that, you know, modifies safety of future pregnancies. But there's generally a treatment that is administered if there's incompatibility detected. So that again is something that they're looking out for and will potentially treat for then afterwards. Hemoglobin and iron studies as well is something that comes up. Generally, like anemia is more common in pregnancy. We mentioned that previously. So baseline hemoglobin is going to be important, especially you know, if you're looking, let's say, if you've got another bleeding disease, that's going to be important. Thrombophilias, that type of thing, or hemophilias. But that's generally something you'd probably be aware of already. But if you're going to have a cesarean section, for example, if you've already got anemia and you're going to have more blood loss, again, that's something that you want to identify early on. So hemoglobin and iron studies, then rubella and varicella, unless there's previous vaccination or exposure, urine dipstick and culture. So again, it's just like a urine sample that's going to be taken, looking for things like, for example, proteinuria. Is there protein in your urine, as mentioned by Nicola previously in relation to preeclampsia? And then asymptomatic bacteriuria. So if you've got bacteria in your urine in the absence of symptoms, again, that's something you can be testing for there. HIV, syphilis, Hep B, Hep C, chlamydia, and then the ongoing process of cervical check. So all those things are going to be kind of part of your standard panel that will be looked for, along with your normal history and examination that would be taken care of by your doctor during your pregnancy.
Yeah, brilliant. And then there's some kind of selective screening that you can do that won't be offered kind of for everyone. It'll be based on kind of symptoms, or if there's a high risk of you kind of having any of these. So kind of thyroid function is one. Again, it's not it's something that's really kind of highly debated, whether all women should have their thyroid function checked during pregnancy, but it's not something that's recommended or done here in Ireland, or in a lot of countries, to be honest. It can be kind of, you know, really important for someone who's, you know, trying to conceive, particularly if they've been trying to conceive kind of without, you know, any luck. There's kind of high rates of kind of subclinical hypothyroidism. That again can be a fertility issue, and once kind of women are kind of treated for that, you know, we can see like an improvement in, you know, like spontaneous pregnancies occurring. So that is kind of one thing that is important that a lot of people don't know about. But yeah, thyroid function, and people can be screened for type 2 diabetes. And then there's a whole load of, I suppose, infectious diseases that, again, it will be dependent if you're kind of high risk at getting them. So like Hep A, kind of measles, you know, again, if you're in like a high risk area, if there's a high likelihood of exposure to any of these, it's not just going to be routinely offered to everyone, like gonorrhea, you know, CMV, HSV, like they'll all be screened for really kind of by your doctor, whether this is something that you need or not.
Yeah, like there's a lot of additional specialized testing, but again, you don't need to think about this stuff. Thankfully, you don't need to know all the different diseases, and depending on your demographics, your background, sexual history, etc., all that's going to modify what your doctor's testing for. So thankfully, you don't have to worry about all that. Now, that takes us from pregnancy. Or is there anything else you wanted to add to pregnancy screening before we go forward?
Yeah, I think that covered the majority of it.
Perfect. Obviously, I suppose we should say is like there are other, I guess, what you could put in the category of screening, for example, for your baby, like your 12-week scan and growth scans and those types of things. But that's a little bit separate. Again, all that's looked after by your doctor. You don't have to go asking for it. So moving on from that, then would be breast cancer screening. This again is probably one of the higher profile, I guess, awareness campaigns in the last couple of decades would be breast cancer. You know, it's not very often that people would know the names of genes that put you at risk of disease, but a lot of people actually aware of BRCA, the BRCA gene, or they might just say the breast cancer gene, because of things like screening or public awareness campaigns. So like breast cancer obviously is one of the more common cancers. And as a result, screening tends to be effective because it meets all those criteria that we mentioned previously. So what are some of the kind of what are the main kind of pillars of screening in breast cancer in terms of, I suppose, first, just the screening tests? Like, what is that process?
Yeah, so I suppose women are kind of, stratified into a few different groups. So whether there's women who have like, an average risk of breast cancer. So the average risk for women is like 15% of women will develop breast cancer at some stage in their life. So that, accounts for kind of 15%. And then there's more kind of people that have kind of like a more of a what we say like a moderate risk, where there's a family history of breast cancer, and high risk screening. So people that might have kind of one of those genes that you mentioned. There's other genes that are responsible and that can be involved as well. So people are kind of stratified in those kind of risks. So generally, the people that are and have an average risk, I guess that's 15%. The moderate risk, then the family history, kind of 15 to 20%. They're kind of really kind of lumped into kind of the same kind of standard kind of the Breast Check Ireland that we all kind of know about. So Breast Check Ireland, it's a free mammogram every 2 years for kind of women between the age of 50 and 69. But so that catches like a huge amount of cases. Now it does miss about 20%, okay, but so the thing is, we know that there's been like huge kind of breast check like campaigns over the years. So we know that this just doesn't start at the age of 50. It's not something that we just need to start at that age. That like even going back, like there's still things that we can do kind of like at my age, kind of 40 kind of and under, kind of the incidence of breast cancer kind of rises with age, and that's why that kind of age 50 group has been identified as the ones that kind of receive the kind of mammograms. Kind of before that, the breast tissue is a lot kind of different, and there's a much higher rates of kind of false positives again. So it's only that age that really kind of catches kind of the majority of like actual positive cases. But kind of before then, and again, this is like, country dependent, but generally under the age of 40, there's kind of no real kind of guidelines for screening. The average risk of kind of developing breast cancer is very low. But as we know, there's, kind of huge campaigns out there. The most kind of widely known is kind of Feel It on the First. So that's kind of people advocating kind of, checking your own breasts, kind of being aware of kind of, what's normal, what's not. And again, there's like really good guidelines online of like, how to check your breasts as well. Like I do recommend kind of going online, even like, the breast cancer groups have like really, really good kind of detailed guidelines of things that you can do yourself. And I suppose the purpose of these is more kind of raising awareness again of kind of, kind of what's normal, what's not. And it's not something to panic. If you are checking and you do feel a lump, or like our breasts change so much even over the month, kind of to do with the menstrual cycle. A lot of women will have just kind of, like physiological cysts that are kind of really benign. And they account for a lot of the cases, probably the majority of the cases that people go and see their GP about, and that are kind of nothing to worry about. Like if you are kind of, one of those people, you will go into the GP, they'll do like a clinical breast exam, and then they'll refer you on to like, like a triple assessment clinic, like a rapid clinic, if necessary, to kind of get that further checked, if this kind of needs a biopsy, if it needs kind of any imaging. But a lot of times, it is something that is just kind of a physiological cyst, but it is important to kind of know what's normal, and what's not, and how to check your breasts as well.
Mm-hmm. So I suppose overall there, what you've got are a few different, like, again, levels of stratification of like how invasive the screening is going to be. So is it just yourself first and foremost, like doing a self breast check? Then you can have a clinical breast exam from someone that is trained and looking for, very specific findings. Then you can have again another level up, which would be your mammogram, and then a biopsy, which is obviously a bit more invasive, looking for specific cellular changes. I think that's all the tests really that would be the kind of first line for breast cancer. Is that right?
Yeah, exactly.
Yeah. So yeah, obviously then if you've got if you're in the higher risk categories, then where for example, there's a strong family history, it's hereditary in the case of BRCA, for example. If you're in those categories, it's going to be a little bit different in terms of when you're going to be screened. It makes more sense in those cases to screen younger rather than screening older. But that again just goes along with the previous points you mentioned.
Yeah. So I suppose with the BRCA ones, because it's something that I suppose gets asked a lot, is kind of why isn't everyone screened for BRCA1, BRCA2, and a lot of women want to get screened for it, again just because there's been so much kind of awareness about it, but there are kind of like criteria for getting tested for BRCA1, BRCA2, and other kind of hereditary genes that might be responsible for kind of breast and ovarian cancer. It's not necessary to test the whole population. Like I said, there just hasn't been value yet in doing that. But the criteria is, breast cancer kind of under the age of 45, they'll typically be screened for, like genetic variants. If someone's kind of age between kind of 46 and 50, if there's an uncertain kind of family history of kind of primary breast cancers, or if there's one close blood relative with breast, ovarian, and pancreatic, prostate cancer diagnosed at any age, or anyone that's diagnosed with kind of triple negative breast cancer as well. And then again, like if someone's kind of found to have the gene, it's not that they're going to develop breast or ovarian cancer. It is so kind of 6% of women kind of with BRCA1, BRCA2 will develop breast cancer, 20% ovarian. But if you are found to kind of have one of those genes, again, you'll be screened, you'll be brought to kind of more of a high risk clinic. You'll be offered kind of risk reduction treatment. And then again, you'll be closely like there'll be close surveillance on you as well with regards to them.
Perfect. And that brings us to diabetes. So diabetes, like for people that aren't aware, you're generally looking for things like, for example, elevations in blood glucose. That can be fasting blood glucose. It can be after an oral glucose tolerance test where, as Nicola mentioned previously in relation to gestational diabetes, you're basically given a glucose challenge of a fixed amount of glucose and then looking for the blood glucose response afterwards, generally at 2 hours. Sometimes it'll be 1 and 2 hours. But you're looking for the response. How high does the blood glucose go? And then over time as well, it can be tested in terms of your HbA1c, how glycated your hemoglobin is. Basically what that means is it gives you a snapshot over the course of about 3 months of what your average blood glucose levels have been. So they're the different types of things that can be assessed for. And generally what that's getting at there with diabetes is that there is altered blood glucose control over time. It's kind of the other side of insulin resistance. So you're becoming more insulin resistant, and then that's more profound in the case of type 2 diabetes, where eventually you can get pancreatic beta cell insufficiency, where you're not producing enough insulin, the blood glucose is chronically elevated, and that puts you at risk of many different diseases down the line, which again is why it's worth screening for, because someone has type 2 diabetes, it's putting them at an elevated risk of things like nerve damage, artery damage, heart disease, and many other conditions along with that. And again, it's not just about saying, are we testing just to tell people they have diabetes? It's also because there are effective treatments, whether they be diet and lifestyle modifications or medications such as metformin, for example. So there are interventions that can then modify the risk of that person having poorer outcomes long term. So that again is why we would screen for type 2 diabetes.
Brilliant. And then the next one then is the colorectal cancer screening. So the bowel screen in Ireland is absolutely brilliant, and it's probably it definitely is kind of one of the lesser known screening programs, but it's offered to people, men and women kind of age 60 to 69 in Ireland. And again, it's really simple to sign up. Kind of you go online, you'll be offered an appointment. You're given kind of a sachet kind of to drink kind of the night before, that kind of essentially kind of clears out the bowels. You head into hospital the next day, and then you're kind of given a scope to check for any lesions. or kind of any kind of, any lesions, again, that could potentially be cancerous and that might be lurking there, but you might be, asymptomatic from. Again, it's a fantastic screening program, and it does kind of pick up, cases that kind of might have been lying kind of dormant there. It's a relatively kind of, invasive, well, it's invasive enough, but, in terms of how invasive it could be, it's a very good screening program, and that's just for kind of the general population. Again, you can have a scope kind of before that age, particularly for the higher risk populations. That might be someone that might have a genetic syndrome that's caused colorectal cancer. People with inflammatory bowel disease like Crohn's or ulcerative colitis, they're at a higher risk of developing colorectal cancer, so they might be screened earlier, but they are screened earlier. And then people kind of depending on their lifestyle, so to do a kind of diet, smoking, alcohol, sedentary lifestyle, and then just the diet is kind of the main one, and obesity.
And just to circle back there quickly, because I never actually mentioned it in relation to diabetes. Sorry to cut off your colorectal cancer discussion. Generally, testing for diabetes generally commences around the age of 45. Okay, but there are a number of things that might lead to testing occurring earlier. So, for example, if you're overweight or obese, that can be an indication for testing earlier. And also, a few of other risk factors like first degree relative with diabetes, history of cardiovascular disease, etc., that might lead to earlier testing. And also, if you have established pre-diabetes, so you'd be tested yearly then for whether or not you've progressed on to full type 2 diabetes. Similarly, if you've had a history of gestational diabetes, like we mentioned in the pregnancy discussion, that would warrant testing then repeated every 3 years, lifelong, effectively, because it is a risk factor for developing diabetes. So once you're kind of 45 years of age, if testing is normal, it's going to be repeated at a minimum of 3-year intervals, and more frequently then if there's a higher baseline risk or an abnormality in the results found. So that just gives you an idea, because I think it's important to note that, like, you don't need, if you're 20, 25, 30, you don't need to just go testing yourself for type 2 diabetes if you don't have risk. We see this all the time in the fitness space, where people are constantly monitoring their blood glucose, and they'll identify, oh, this food sent my blood glucose to, I don't know, 8 or 9 after a meal. Like, oh my God, am I insulin resistant? Am I diabetic? It just causes unnecessary stress. People not eating fruit because it increased their blood glucose and this type of thing. So that's kind of one of the risks of over screening in this case. So that's just an important note there, because it comes up all the time in the fitness space. But yeah, I think you mentioned everything that we wanted to get through in terms of bowel screening. That's the colorectal cancer, that's diabetes. And then the final thing is bone density. So this comes up all the time with women in particular, considerations related to osteoporosis, osteopenia, etc. So is it the case that everyone should be getting an ADEXA, or where are we at with this? Who should be screened for bone density issues?
Yeah, so I think throughout this series, I think I've gone on about osteoporosis in women so much, but talking about it again, I suppose. So yeah, we all kind of know about the DEXA scans. That's kind of checking your kind of bone mineral density. So women over the age of 65, kind of, and without any other risk, they should all kind of receive a DEXA scan to check the bone mineral density, and then following on from that, so kind of a younger age, so younger kind of postmenopausal women, kind of age kind of 50 to 69, kind of with risk factors, they should have a DEXA scan. So anyone kind of that's had kind of an unusual kind of fracture under that age, or anyone with a certain conditions, whether that's kind of rheumatoid arthritis, whether they're taking steroids that might kind of decrease kind of their bone mineral density, that sort of thing. But again, it'll be like risk stratified, with something that your doctor, your GP will go through and put you refer you for one.
And thankfully this, like, our primary podcast demographic is like 25 to 35, most of our listeners. So most of you probably don't have to worry about that. But in some cases, it can be, of concern for some women. For example, we talked about amenorrhea previously in previous episodes. And, if you've been amenorrheic for a long period of time, especially if you're, in that hypothalamic amenorrhea spectrum, maybe over dieting, chronic exercise, etc., you can run into some bone density problems in those cases. So again, I'm not saying it's irrelevant for younger populations. It can certainly be relevant, but generally the kind of high yield screening is going to take place in slightly older populations. So they're all the major conditions that we've gone through, I think, in terms of screening in women. Now, it is a lot. There's a lot of different things that we've discussed. And I think one of the points that we have kind of repeated over and over is that a lot of it is looked after by your doctor, especially when we talk about pregnancy. And I think one of the important things to do here is not to put all of the responsibility for screening like in your own hands and saying like, right, what do I need to test for? What tests do I need? Like, speak to your GP about this. Say, look, right, I'm 30 years old now. I've had one kid or whatever. I'm really starting to become a bit more health conscious. I'm just wondering, what testing should I have done to benefit my health right now? Or when should I be thinking about getting testing for this or that? And that's generally the best way of trying to at least organize it in your own mind. Because if you go online and you read about different testing, like, it can be very overwhelming, especially if you follow a lot of people, I think, in the health and fitness space, because generally we can be very neurotic sometimes. You'll have totally healthy people testing for every hormone and vitamin under the sun to see if there's any problems, and often it just leads to just unnecessary worry. You generally don't need to do that, and that's why we wanted to put together this episode where we just give you the high yield items. You can at least get some exposure to that, and then you can discuss it with your own doctor as to what's most appropriate for you right now, given your current state of health, family history, circumstances, etc. Is there anything you'd like to cover before we finish up?
No, I think that like there's loads more that you can go through there, but I think those are all kind of, the main ones.
Perfect. So that kind of concludes this episode. And in the next episode, what we'll be doing is trying to basically close off the women's series and summarize the most important things to be aware of as a woman that is, interested in fitness, but also just generally health conscious. What are the things that you should be doing? What are the things that should be screened for? We'll very quickly summarize these recommendations because we did a full episode on this, and just give you an overall idea of women's health and fitness. So with that said, we do have a more personalized service too. We do coaching. So if you'd like to, take your own goals to the next level, obviously we don't offer health screening, but we can offer training and nutrition recommendations, lifestyle recommendations, etc., to improve your health. We like to think, also improve your fitness and those types of things. So if you'd like to work with us to improve your health, performance, body composition, etc., we have a team of very competent coaches who can help you on that journey. We also put out a ton of free information. You can subscribe to our newsletter. You can follow us on social media, Triage Method, and all of our individual pages. We've got a lot of free content there. And then what you can also do is, what was I going to say? Join the Coaches Corner. So we have an educational platform at the moment. It will be evolving into something very different very soon. But at the moment, you can subscribe there, get a lot of an access to a ton of content there. It's relatively cheap service. So if you'd like to take a look at that, you can do so. And then if you like the podcast, you enjoy what we're putting out, we always appreciate a review or rating if your app allows for that. And also if you share it on, your Instagram story, WhatsApp group with friends, privately with a friend that you think would benefit from the podcast, it helps us get the word out there, and we really do appreciate it. So that's it from me. Thanks very much for listening, guys, and we'll see you in the next episode.